Right, so good afternoon, everyone. My name is Matt Gasecki, and I am the Community Outreach and Education Coordinator with NAMI Greater Cleveland. And I am very pleased to have so many of you on the call with us today for this very important topic on mental health and older adults. This program is being recorded, so please be aware of that. If you don't want to have your camera on, make sure that it's turned off. We are going to have time for questions and answers in the last 10 minutes of the program. Please remember to stay muted. Please also utilize the chat feature if you have questions throughout the presentation. We will have time to answer them by the end. I will allow our speaker, Tam Cooper, to introduce herself and talk a little bit more about the Benjamin Rose Institute on Aging in a moment. But first, I would like to tell you just a little bit about NAMI Greater Cleveland in case this is one of the first programs that you're attending with us. NAMI Greater Cleveland is the local affiliate of the National Alliance on Mental Illness. NAMI is an organization that was founded in 1979 in Wisconsin by a group of mothers of children with mental illness. And they formed NAMI as a kind of grassroots coalition around their kitchen tables because they were experiencing the lack of understanding and support and acknowledgement in their local communities around the reality of living with mental illness. Today, NAMI is the largest grassroots mental health organization of its kind, and it is represented by state and local affiliates in all 50 states. And NAMI Greater Cleveland, as I said before, is the local affiliate that serves Cuyahoga County, and we support our community peers with mental illness as well as their families through providing education, support, information, and referral and advocacy. We offer support groups for people with mental illness as well as support groups for their families. We offer educational programs like this, as well as do education and outreach to audiences such as law enforcement, college students, and middle schools and high schools. And we also have a helpline that's available Monday through Friday, 9 to 5, where you can call if you have a request for information or referral to sources in the creator community that may be helpful for you or a loved one experiencing a mental health condition. And NAMI also supports advocacy in the sense of raising awareness about mental illness. NAMI is very involved at the national level in research, as well as in legislative advocacy at the state and national level around making mental health a public health priority and just promoting greater funding for mental health and more humane treatment options as far as mental health and substance use treatment is concerned. So that's a little bit about NAMI. You will have access to the slides for this presentation after the fact, and the recording for this presentation will become available on the NAMI Greater Cleveland YouTube channel later this week, most likely tomorrow. So with that being said, I think I will hand it over to our presenter, Tam Cooper, to talk about herself, Benjamin Rose, and to get us started.
Good afternoon, everyone. Hi, I'm really pleased to be able to do this presentation on behalf of NAMI. My name is Tam Cooper. I go by Tam, and I'm the Director of Behavioral Health Services at Benjamin Rose Institute on Aging. I'm a licensed independent chemical dependency counselor, as well as an LISW. I've been in the field about 30 years, and I have been with Benjamin Rose 11 years. So what I'd like to do is just tell you all a little bit about Benjamin Rose, which has a really great history here in Cleveland. So we are a 112-year-old Cleveland-based nonprofit organization, and we're recognized as a leader in our mission to support caregivers and empower all people to age well through research, consumer responsive services, and client advocacy. Next slide, please. We really do a lot at Benjamin Rose, and annually we reach more than 10,000 older adults and caregivers at community locations, homes, and by phone and email. And what makes us unique is we're the only agency here in Cuyahoga County that focuses solely on services for adults. We have a research component. We develop knowledge used to improve health and community services related to key issues in aging. And we also foster informed engagement with public policy issues impacting the field of aging. Next slide. We have a number of subsidiaries. Some of you may be familiar with them. Of course, there are Elder Care Services Institute, which our behavioral health services is part of. ESOP, Empowering and Strengthening Ohio's People, which really is our financial and housing arm. One thing that they do, they've been doing free taxes for older adults. Row centers for aging well. We have 7 of those located throughout Cuyahoga County, and a number of years ago, they were called the Golden Age Centers, if some of you have been around for a while. Margaret Wagner Apartments, it's senior apartments located on Euclid Heights Boulevard. And we have our Center for Research and Education, which really is a powerful branch of Benjamin Rose. They do a lot of grants, they do a lot of research with elder abuse. And then lastly, we have something that was developed out of our research program through quality insurance. It's a program called We Care Because You Do. And it's a telephone-based care coaching model for older adults and their caregivers. So that's a little bit about some of the many things that we do here at Benjamin Rose. Next slide. So today, what I really want to focus on is, if you will, a cursory overview of mental health as it pertains to older adults. Again, Benjamin Rose works with adults age 55 and over and their caregivers. So I hope when we finish that you'll have an increased awareness of some of the signs and symptoms for the common mental illnesses, which typically include anxiety and depression. That you'll learn a little more about how anxiety and depression may present in an older adult, and that you may be able to identify some treatments and some ways to respond to somebody who has experienced a mental health concern. And you may notice that when I talk, I don't use words like senior and elderly or frail, because really, you know, we want to talk about this as an older adult. Things are changing, you know, and we don't want to look at ageism. So next slide, please. So what is mental illness? Well, it's a disorder that affects a person's thinking, feelings, or moods. Now, a mental illness may affect one's ability to think rationally, or their ability to exercise control. And it may become challenging to care for yourself on a daily basis. And a personal thing that I would like to say is there is no shame in having a mental illness. And that's something that society and we as professionals still need to keep working to fight that stigma. You know, we have heart attacks, we're overweight, we have cancer. There's no shame. There should be no shame or no stigma associated with mental illness either. Next slide. More than a stereotype. Oh boy. Some of us are of the generation where we look at, you know, whether we're a caregiver or an old person, boy, they're just stubborn. They don't want to do something. Oh, you're just slow because you have arthritis, or you're slow because you're just being cranky. Some of the other stereotypes for older adults, you know, seniors, you know, it's expected that you're forgetful and that you're confused, or you're mean because you're aged. Well, that's not true. And, you know, all these assumptions cause us, family members, people in the community, maybe you're standing behind somebody in line, to dismiss that mental illness in older adults, and also people that are not familiar with this that may be working with them, you know. Next slide. So for those that aren't knowledgeable about this, you know, how does mental illness present in an older adult? Well, when you know someone and you start to see change in personal hygiene or standard of living. Okay, you know, when once the person was pretty clean and organized or dressed well, you know, all of a sudden you start to see that they're not cleaning their dentures every day. They're not washing their face. They're not changing their clothes. They're looking kind of schlumpy. And this isn't just our pandemic era where we rolling out of bed in our PJs and or just changing our top for the Zoom, you know, meeting, right? Confusion, some poor concentration and trouble making decisions. Now, all of us go through that at different times for stress or we got a lot going on. But if you notice that there's a pattern and you recognize that the person's lifestyle hasn't changed much, you know, something could be going on. Change in appetite or weight. And it has to be significant. I'm an emotional eater at different times. I reward myself with food. If I'm bummed out, I may decide I'm going to eat more, but it doesn't interfere with my life and it's not a consistent every week or every day kind of thing. But again, it's really being alert and noticing what's happening with that particular person. So if you're with this older adult, maybe you're working with them as a professional or a neighbor or something, and you start to hear that person talk about or express feelings of worthlessness, guilt, helplessness, or self-harm. And those feelings can be, you know, just straight up, you know, I don't feel like living, I feel really bad, I have regrets, or there's the type of people that joke a lot, self-deprecating remarks. So being attuned to that, if you hear more and more of that, again, that should be a red flag. And obviously self-harm, and self-harm can present in different ways. If the person, you know, as a number of people get older, there's tend to be falls risks. Some of you may be familiar with. Take a look at what falls are. Is the person drinking more? Sometimes people don't associate falls with increased drinking. Or is the person intentionally engaging in some type of high risk behavior?
Why can I hear nothing?
Okay, next slide, please. Oh, can you go back? Matt, go back another slide. Next one. Oh, I thought I saw one there. Okay. Yeah, the 1 in 5. Are we skipping a slide? Somehow. Go down.
No, I don't think so.
Oh, looked like something was skipping up. Okay, next slide. So again, short-term memory loss, a loss of interest in a lot of the activities. It doesn't even have to be in things that they just like to do, but you know, all of a sudden, people don't want to leave the house. People don't want to watch TV, napping a lot, or insomnia, just being awake a lot. Okay, next slide. There we go. So statistics show that about 1 in 5 adults has a mental illness in any given year. And mental illness can begin in any age, from childhood through later adult years, but most cases begin earlier in life. Some of you may have heard of like early onset schizophrenia, or there's anxiety and such. You can also have more than one mental health disorder at the same time. Anxiety and depression. Depression and post-traumatic stress disorder, there can be addiction, etc. Next slide. I think it's important for practitioners and family members to recognize at what point is this just not a case of the blues, you know? Because untreated mental health issues can really cause severe problems. And those problems can result with family conflict and relationship issues. Anger is depression turned inwards, right? It can cause dependency on alcohol, tobacco, drugs. I don't know if any of you have known people or maybe even been in situations yourself when you become so depressed, you just give up on anything, your hygiene, you don't pay your bills, maybe you don't go to work, and it just becomes a vicious cycle. Chronic stress, it weakens the immune system. You know, you become sick, you're not eating right, you're not exercising. There are higher rates of heart disease and other medical conditions. And self-harm and harm to others, including death. So being aware of that. Now, there are some risk factors for mental illness, and there's a variety of different things. Inherited traits, direct relatives are diagnosed with a mental illness, previous history of a mental illness, chronic medical and physical conditions. And, you know, that makes sense. I mean, if you have all these problems, you know, who's not going to be feeling sad? Environmental exposure, PTSD from rape, military combat, robbery, and most recently we've been doing at Benjamin Rowe's program on being targeted by cyber crimes, romance scams, abuse, stressful life conditions, and then there's neurological factors, chronic medical conditions, like again, like a neurological diseases. Next slide. But I caution everyone to understand that depression, like dementia, is not a normal part of aging. Okay. It's a complex condition with mental and physical symptoms that interfere with a person's ability to function, but it is treatable. So again, it's not, you know, when we look at the stereotypes, oh, they're old, your life's over, you know, what have you got to live for? I mean, we're living, we're breathing, you know? So feelings of hopelessness, loneliness, and sadness that last more than 2 weeks, that's a clinical diagnosis, depression, quick and dirty, accompanied by fatigue and other symptoms. They can be treated, going to a therapist and also seeing qualified physician, psychiatrist for appropriate medication. Next slide. And we've already talked about recognizing depression in older persons. So when you get the slides again, you can take a look at them. You know, what are some of the things that you need to recognize? Next slide, please. Some of the high-risk populations for depression include women, single, divorced, or widowed. And you may wonder why. Well, it's a lack of social support. Everybody, you know, it's human nature to want to have companionship. Physical conditions that cause chronic pain. And then a history of addiction or addictive behaviors. Next slide. The most common mental disorder among older adults isn't depression, it's anxiety. And I always found that to be interesting. Next slide. Common worries, deteriorating health, financial concerns. Oh yeah. I wonder if anxiety isn't common even in other age groups. Older adults diagnosed with an anxiety disorder worry excessively about routine events and activities for 6 months or more. And you know, when you think about it, as we age, there's a lot of changes. You may lose your spouse, your housing changes, your health changes, you've lost friends. For many older adults, pets are significant. That long-time pet passes, you know, that's family for a lot of us. So it's a major loss. And then those feelings of intense fear and distress that are overwhelming, and they can prevent older adults from doing a lot of things. You just don't want to, you don't want to do anything. You're afraid. Next slide. So there's emotional and physical components, you know, apprehension or dread. You know, you just don't want to try anymore. You're tense and jumpy. That hypervigilance, that startled reaction. You know, did you ever walk in on somebody, say, hey, and the person's like, oh, you know, just jumps. Restlessness or irritability. And it's not just, again, not just the isolated piece, but watching to see how that is all the time. And anticipating the worst, being watchful for signs of danger. And that also, you know, anxiety is a piece of post-traumatic stress disorder, hypervigilance, always wondering what's going to happen next, scanning the area, combined with trauma. Physical pieces, you know, pounding or racing heart, shortness of breath, upset stomach, sweating, tremors, twitching, headaches, fatigue, insomnia. Now, anxiety is the lesser of a panic attack. So some of you, if you're familiar with a panic attack, probably recognize some of these symptoms that I'm talking about. Now, anxiety can mimic some signs of dementia, the agitation, which comes from sundowning, impaired memory, and fear. Always, always, if you see that or any of these with someone, a loved one or someone you care about, have them see a physician for diagnosis and treatment. I mean, this is needless suffering, and we don't want that for someone. So, what are some signs or triggers, again, that we should look for? A lot of the similar things: poor daily self-care, presence of chronic or severe pain, previous history of depression, recent loss of a loved one, including a pet, sudden and extreme changes in mood, someone who might become violent, threatening, or aggressive that never was before. You know, that's that irritability ratcheted up. Alcohol or drugs. And people that use and abuse substances, especially older adults, some of them may have had a history a long time ago and they had stopped drinking. And then all of a sudden they're using it now as a coping mechanism. And it's really interesting. I've had some older clients, you know, it's alcohol and drugs are extremely powerful. Do not doubt for a minute that there aren't some people in their late 60s that are using heroin, that are using sedating drugs, Oxycontin, that are drug seeking. But also, by the same token, there are older adults that need narcotics for pain management. But if you are someone who has to go into the home, you know, is paying attention, there's also cases where medication is being taken by other people, you know, taken, when I say taken, you know, snitched by other people who come into the home from that adult. People who appear confused or hallucinating. They're talking about suicide and showing little to no interest in activities, and just in general being fearful, panicked, or paranoid. Next slide. So how do we talk to these people? Well, it's really important not to be accusatory or dismiss somebody's symptoms, because the quickest way to turn somebody off is to be blaming. So be respectful and listen. You know, hey, what's going on? And, you just don't seem yourself. Yeah, I'm fine. No, I care about you. Things just seem kind of odd. Can you talk to me? And that first conversation may not go well, but you keep coming back. And hallucinations and delusions are real to the person. Don't try to convince them that, Joe doesn't live in the closet and you have to give him a plate of food. Talk to me about Joe. What does he like? What doesn't he like? How often does he show up in the closet? Try to make some kind of connection so that you are able then to hopefully get the client to go to the doctor and say, maybe we ought to visit the doctor. So maybe he might tell you something about how to help Joe in the closet. Find a way to manage the needs realistically. And it's always a different thing when you are living with this person. It can be very stressful if you're a caregiver. So there are a lot of options to work with that. So you set limits if necessary. You always try to establish a trusting relationship, whether you're a caregiver, whether you are a professional. If the person is experiencing paranoia, you give that person more body space. You do not want to get too physically close to somebody who is actively hallucinating and being paranoid in a way that may be threatening. And you talk in a calm and quiet voice. And the reason you do that is because then that forces the person to lower their speech and it calms them down. If you talk loud, they're going to talk loud. You talk softer, they're going to talk softer. Things to avoid. And this is more if you are like encountering this person out in the community. And imagine this, say you're with someone and there's a group. The person's already confused. So if I'm talking to them and Matt comes up and Matt tries to talk to them and then Jane comes up and tries to talk, the person's already confused. So it should be one person talking to this confused individual, not a bunch of people jumping in. You don't lie when you see, you don't see Joe in the closet. And you don't make up stories, but you do try and get the person to time to get that person to go to see a doctor. Whatever you do, again, a body distance. Anxiety, you don't want to increase that level of anxiety or agitation. Now, what's aggressive body language? I'm kind of a talker with hands. That's not so good. If you need to hold your own hands in front of yourself so that you don't do that. And I think if you are a professional, and I don't know if you tend to see people in your office, you want to make sure that you don't have anything that somebody could use as a weapon. And when I say weapon, it could be a pair of scissors, it could be a pen. I'm sure some of you have had training. You don't want your back against the wall. You want to be able, if something escalates, to be able to leave the office because things pop off pretty quick. And they could use anything. They could use a phone to try and assault you with. So, and again, being calm, being quiet, lowered voice is important. Do not insult someone. So when it says, do not assume that a person has a cognitive impairment, I've seen some students or some people new in the profession that I've had to supervise or in the field that will all of a sudden start talking really slowly. And it's obvious they're acting like that client is, impaired, that only makes the person angrier. So it's using a lot of judgment, and not being sarcastic. And do not assume that they are under the influence of recreational, and I would also say even overprescribed prescription drugs, especially for the older adult. But again, as I said, it's people, older adults, get high, use marijuana, heroin, any kind of fentanyl. The power of that high, or chasing the dragon, it doesn't care about age or socioeconomic status, gender. People are going to use. I feel pretty passionate about this issue of mental illness and violence. I personally struggle when I watch the news that anytime some violent act is committed on some stations, people want to immediately jump to say, oh boy, you know, does a person have a history of mental illness? Mental illness alone does not increase the risk of violence. Ooh, that just drives me nuts. You know, there are some people that maybe have some history, but no, that's not the way it is. There are other risk factors that are present. Substance abuse, and people don't just snap and run out with a gun and shoot people or stab people. There's either a long-term time of some type of indoctrination, grooming, they're harboring and nursing some kind of a grudge. I don't know. I mean, I don't know. I can't see my audience, so I don't know. I'm assuming it's a broad reach of professionals and public and family members, but it is so frustrating to hear that. And I will say this, and this is my opinion alone, it's sad on both ends. It's sad when the person hurts somebody else. It's sad for the victim. It's also a sad commentary that the perpetrator, whatever happened, that they had to strike out. Certainly we want justice, but you know, as we are as a society, we as mental health practitioners, I think, don't get the recognition that we deserve. We as social workers don't get the recognition that we deserve, because we are truly a society that's in need of caring for our mental health and not having it put aside. So, you know, if you are a practitioner or you are a family member that's caring for someone, be proud of the job that you do. Be proud of the activism that you do, because we need it maybe now more than ever. Next slide. So how do you respond to somebody that maybe is a neighbor, or maybe somebody that you're working with, or maybe someone has come to you and said, geez, you know, I know someone who's going through this. You know, I'm going to tell you two things. Be sincere. If you're not interested, I would say, tell them to call a professional, a local agency, refer them to someone, because if you're just being disingenuous, you're not going to help. Otherwise, you know, sincerely express concern. It's another human being. You know, and offer support. You know, how can I help you? Here's some things that we can do. And at the end of the presentation there, I think I have some local resources that we can point out. Now, this is a human being. treat the person the same way you did before the crisis. Think of it this way, treat them the way you'd want to be treated, or how you would want your loved one to be treated if they were in crisis. And if you don't know them, if it's a stranger that you see in distress, the same rules apply. I don't know, last year or 2 years ago, I was driving home, and there was a car parked sideways on a two-way street, and these cars were beeping the horn, and I was right there. So I got out of my car, and it was a older woman, and she was disoriented. I guess she thought, I said, how can I help you, ma'am? Oh, I'm trying to get to Mayfield or something. She didn't know where she was. I guess she thought she was in her driveway. And I said, hey, and how about we just pull over here? Oh, I'm just trying to get the directions. And people were just hotter than heck. Nobody wanted to help her. So I said, how about I hop in the car with you? And I know I probably shouldn't have done that, but I thought I got to get this woman out of the middle of the road. So we pulled across the street, waited till all these cars went by, and people are giving us the finger and all. I mean, it was just terrible. Nobody wants to help. Turned the car around, drove her back in the driveway. Somebody was there at the house. I pulled my car out. I could have stood there and done the same thing, but I thought, what is the purpose? And I did not know her. We need to help one another. And something was wrong. All right, that's my little spiel there. But so respect and concern go a long way towards stabilization. Even if somebody is really angry with you. I don't know if any of you have been in situations, they have a right to be angry. Now, I'm not going to diagnose that woman. I don't know anything. That's up to medical experts. I'm not going to tell you what kind of medication to take. That's out of my scope of practice. But I'm going to try and connect you with a physician or a psychiatrist. So that's where I'm at. So in an emergency, oh boy, if a person's agitated, unresponsive, you call mobile crisis and you explain the situation and you listen to their advice. Too many people want to play, I don't know, what is it? Chicago ER, or they want to play TV, right? Egos. Don't diagnose or assess for suicidality. You can just, if something's going on, self-harm, you tell the people on the end of the phone, they've cut themselves, they've done this or that. You manage the environment. You try and get the person to be calm. Safety first. You be concerned about your safety, because if you're not safe, you're not helping them any. And if you need to call for help, I tell my staff, because I supervise a lot of people, I said, you keep your cell phone on you. I don't care. I had one woman who did, I don't carry my, you need to keep, because it's when you least expect it. You're walking to the bathroom and something bizarre is going to happen. My phone only rings when the moment I get out of my chair. Some of you, I'm sure, are telecommuting, right? You sit in the chair 6 hours, the 1 second you get up, right? The phone rings. So have it on you. So if you need to call for help, it's there. Next slide. And a final thought, and I think I've talked about that in this presentation, take care of yourself. And I'm not just talking about if you are a caregiver that's facing a difficult situation, but even in our society today, there is no shame in admitting we need help. These are hard times. We have come out of some of the thick of COVID, but things have changed so much. There's variants, changes with relationships and jobs and the economy and healthcare. If you're not taking care of yourself, you can't take care of someone else. Easier said than done, right? Because many of us are nurturers, we're rescuers, social workers, nurses, everybody else They think it's a 40-hour job, 40-hour-a-week job. Well, it's not. You know, it just goes on endlessly. So, and you love the person that you're with. You don't want to see them suffer. So what do you do for self-care? Relaxation, calming activities, reading, see a therapist. Let's walk the walk, support groups, time for yourself. And really remember, it's okay to ask for help. More so now than ever. It's okay to ask for help. And it's okay to not be okay. So for Benjamin Rose, if you are interested or you are a caregiver or know an older adult, you can either call and ask for our intake department, 791-8000. We have an email. I'm the director. If you have any questions, we also do presentations at different places. Again, I'm really ticked off about these criminals that are doing preying on older adults, romance scams, cyber crimes. So we've been trying to look at the mental health impact on trauma, whether it happened just a couple days ago or 15 or 20 years ago. It's something that needs to be dealt with. So I'm going to open it up for any questions or comments, if you will.
Thank you, Tam. Yeah, so if anyone has any questions, feel free to put those in the chat. One question that I wanted to ask, something that occurred to me while you were presenting, was the piece about generalized anxiety disorder and some of its symptoms being similar to or confused with dementia. I was wondering if you can talk a little bit more about that, the parsing out there, if you can offer any suggestions for those of us that are, perhaps touched by Alzheimer's disease or other forms of dementia, or have aging loved ones who, may be experiencing anxiety instead of what we might think is the early onset of dementia. If you could just talk a little bit more about that particular piece.
Sure. And remember, again, I want to caution everybody that it's always important to get a really good geriatric workup, whether if Foley Center is great, university, and I'm not endorsing anyone, I'm just talking about some options. University Hospitals has a good program to look at a geriatric workup, but some of the signs and symptoms, and I see somebody saying, what's the difference between dementia and mental illness? Yeah, dementia is not considered mental illness because dementia has certainly some neurological components in terms of a deterioration of parts of the brain. And what you see with anxiety and dementia, some of the crossovers are, let me talk about irritability. So dementia is progressive and it gets progressively, dementia, well, let me step back. Alzheimer's gets progressively worse. You can have dementia that's induced by medication, okay? And you could have a dementia that may have been a result of a brain injury. Alzheimer's, again, has been the result of type of deterioration, and it's chronic condition that's deteriorating a component, your brain. There's no cure for Alzheimer's. This is one of the biggest scams for older people is people selling bogus like snake oil Alzheimer's disease medication because they know people want to cure it. But let's talk about anxiety, your question, irritability. All right. When we're anxious, we're worried and concerned, right? We're irritable. That irritability level usually kind of stays the same unless there's some sort of something different going on. Like if you're naturally anxious, you're naturally a little irritable, Okay, then say your job becomes a little more frustrating or there's a relationship issue, it might ratchet it up. Okay, so along with Alzheimer's, if that's one of the presentations, that irritability is either going to progress even more. Okay, and you're going to see a lot more changes, such as, the end result is someone who just totally is not able to feed themselves. They totally forget how to do everything, can't feed themselves, inability to walk, loss of control of body movements. And I think I heard you say how if we're worried about whether we have that, again, I would say you go for a geriatric workup, you look to see if there's a family history. There's not always a family history, but it's a good or a strong predicator that there might be. Sundowning. Now, sundowning, which means being more irritable, not being aware of what's going on. That doesn't always happen, as the name says, when it gets later in the day. Some people become more disoriented in the morning. In the afternoon, it's patterns. And usually only people that are around that person more often can tell that. If you're in a nursing home, you have an aide that can see it. Say you're a loved one that lives with that person. Again, I can't encourage people enough to go to a doctor. And mental illness, it's, there's differences between how some of the chemicals in the brain or the serotonin reuptake, some of those chemicals are processed, but it's not necessarily a damage. And mental illness, for the most part, can be managed with therapy and medication. Pills alone aren't going to do it. So I hope I've answered part of that. And some of these
Yes, thank you. Definitely. Looking at the comments, I'm trying to find some of the questions.
It says what to do if someone refuses to get med. I guess that kind of flopped away. If somebody refuses to get care, well, I mean, it's always an individual situation. People have to be voluntary. It depends. Are they living alone? Are they at risk to themselves or others? Are they managing? Sometimes you can call an APS, sometimes you can do an intervention. Sometimes you have to wait it out. And that's not what a lot of us want to hear, because I don't want to see somebody suffer, but you can't twist somebody's arm.
Another question that was in here was, let's see if I can find it. What are some resources for reducing isolation for older adults?
Oh, okay. Well, there's some, particularly now, it's really good. Benjamin Rose, one of their components is the Rose Centers. And what they're doing, they have something called Rose on the Go, which they'll go and drive to people's homes, and they have different activities. We also have been doing telehealth. So, and along with the telehealth, for people that have broadband or access to Wi-Fi and that are willing to do this, we had a program where we got tablets, they're not I'm old. I don't even know what the names are. They're not like what you call them?
iPad.
But they're like them. And so we have been giving them to clients, but we're also teaching them, they could keep them how to use these, use them for telehealth visits, but also how to, do socialization. But then we would teach them too about the nasty side. You know, you don't want to, you need to be aware so you don't get cyber scammed and all that. So, you know, things are opening up. So there's some really cool things. If someone's interested, they could call that 791-8000. But there's a lot of agencies and a lot of different things. The libraries, RTA is, if you're mobile, has a reduced rate. Senior transportation, you know, where you can go shopping and do some different things.
Yeah, it looks like some folks are adding suggestions in the comments as well. So thanks to those of you that are.
The library is a great place to do stuff. You know, if you are mobile, and if you're not, you know, reach out to some of the different DSAS. There's different programs all over. Of May Dugan.
There's another question.
Alcohol and Drug Board, a website. Or if you have if you are a caregiver, look at the Cuyahoga County Alcohol and Mental Health Services Board, and they list a bunch of activities, and you can even reach out to them to say, hey, what can I do for a senior? For an older adult, senior, slap my face, older.
There was another good question in here. Can you elaborate on how caregivers can set limits?
I'll probably take it.
It all depends again on the situation. Caregivers need support. We have, and here's again, and I'm not trying to sound like I'm Benjamin Rose, but this telephone coaching model that we have that's called We Care Because You Do, they work specifically with caregivers, and it's free. There's like 3 sessions that are free. They, if you call up intake and say, I want to learn more about We Care, they hook you up with a coach. You have the same person. They give you local resources. They talk to you about how to manage your stress as a caregiver, when it might be time. You know, sometimes we hang on too long, and I get it. You know, maybe it's time that you need more help with your loved one. I don't know if they use the term anymore, sandwich generation. Is anyone familiar with that, where
Yes.
ours grew up and we had to take care of our family? So when you say about setting limits, I think I would be remiss if I just rattled off different ways. Again, it doesn't cost you anything to call up that 791-8000, you ask for intake and say, you know, I'd like to talk to somebody in your We Care division. They're awesome. They're professionals. They've been trained in this, and they can give you some really good tips on how to manage this.
And there was another question, do the Benjamin Rose senior or the housing apartments, are those for men and women?
Men and women, subsidized. Yeah, it's a HUD. I think it's HUD housing. Yes, it is. Dorothy Fuldheim was there many, many moons ago. If anybody remembers Dorothy Fuldheim, what was that, Channel 5?
Any other questions? Feel free to put them in the chat. I did put the link for the evaluation for today's program, so please do complete that. And if you have a second, I just put it in the chat again. It's a SurveyMonkey link. It's an anonymous survey. Just takes 2 minutes to complete. Really appreciate maximum completion on that, so that we can continue to offer programs like this free, you know, to the public. I will.
If anybody has any questions, you've got my name, phone number. Email is sometimes the best. Please email me. I'll be more than glad to answer. I might not be able to answer that day or right the next, but I assure you I will, because I've had my boots on the ground. I'm very passionate about this, and geez, I've been isolated for a couple of years, so I really love being a social worker more than anything, and maybe not so much being a director. But I want to hear from you, and I want to help. So please feel free. And
Yeah, what is your email, Tam? I'll put it in the chat
It's
for them.
T Cooper at benrose.org. There you go. T Cooper
I
at
also,
benrose.
for those of you that joined us halfway through, this is being recorded and will be posted to our YouTube channel later this week, so you can watch it in its entirety. And I will also be sending out via email the slides from today's presentation so that you have all that good information and all the contact numbers that were provided during the presentation. Thank you all for being here for this important topic. And thank you, Tam, for being so generous with your time and your expertise on this really important topic for our audience.
Thank you. I really appreciate it. I hope to hear from some of you. Have a good one.
Thank you. Bye, everyone.
Bye now. Thanks, Matt. Thanks,
Bye.
everyone.